Thank you, professors and Dr. Marie. So now to move on to our second session, applications of focused ultrasound in gynecological disorders. So our session chair and moderator for this part will be Dr. Grace La Portesa. She's an active consultant in St. Luke's Medical Center, QC, Quezon City. And she's also a member of both the Philippine and International Society of Ultrasound in Obstetrics and Gynecology. Dr. Grace La Portesa.
So good morning, everyone. Welcome to our second session, which is about the applications of focused ultrasound in gynecological disorders. So for this session, we also have three speakers who will be discussing this topic. So let's go on to our first speaker. He is an obstetrician gynecologist and a subspecialist in reproductive medicine at a private hospital in Melaka, Malaysia, where he heads the IVF Center and the HIFU Center. He is also the past president of the Asia Pacific Association of Gynecology Endoscopy and of the Obstetrical and Gynecological Society of Malaysia. He also started the first HIFU Center in Malaysia in 2021. So here to discuss infertility with uterine fibroids and adenomyosis and how HIFU can help, let's all give a round of applause to Dr. Sibela Raja Supermaniam, or Dr. Selva for short.
Firstly, I want to thank the organization for inviting me to speak on this topic. It's a difficult topic, infertility with fibroids and adenomyosis, like someone has asked. I'll try to answer your questions, but I don't have the answer to all the questions. Okay, I did my disclosure. I run a HIFU-based, ultrasound-based HIFU center at Makuta Medical Center, Melaka. And this is my experience. I'm very young in terms of HIFU. My teacher is Professor Zhang Liang and Dr. Hermin, both of them are here. And I have done for about 3 years, 605 cases, 214 adenomyosis, and 391 are fibroids. But that is not all. I have been doing IVF for 26 years. I've been doing laparoscopic surgery for 30 years. So with this background in mind, I'll try to give you a perspective as to how to adapt HIFU for patients with infertility. I think without infertility, in my mind, it should be first line. But for infertility, it is a little bit more tricky because we IVF specialists have got some concerns, and also we laparoscopic surgeons want to do our laparoscopic surgery. So where will HIFU fit? So first, let's look at uterine fibroids. Now, we have a very good option for uterine fibroids. We can do surgery. We can do myomectomy. And the advantage of myomectomy is, how do I get a pointer here? Okay, the advantage of myomectomy, everybody knows, is fibroids is removed from the uterus. Many women like this. I don't want the fibroid in my uterus. I want it out. Fine. We can do it by open or by laparoscopic surgery. The other advantage is that we have histopathology. We have histopathology when we do this. In HIFU, what are the advantages? Okay, there's no abdominal scars. It's done under sedation, fast return to activities, minimal complications, less post-operative pains. We know all this. But I think the most important advantage is there's no scar in the uterus. Yes, we kill the fibroid. The fibroid is still there. It's slowly shrinking. It's got a capsule. The myometrium is intact. So I think the question of whether the patient can have a normal delivery is probably out of the question. They can have a normal delivery. And also they can conceive earlier because we have not disrupted the myometrium. We've not cut the uterus. We've not sutured it. I mean, those who are us to do surgery, we sometimes after finishing the surgery say, what have I done? I have mutilated the uterus. I've taken out all the fibroids and tried to put everything together. But the patient still gets pregnant. Good. But here we are not doing that. We are killing the fibroid and we are waiting for the fibroid to die within the uterus. So they should be able to conceive earlier. 3-4 months if they want to get conceived, and they can have a normal delivery. And also, if there is a recurrence always occurs, we can do it again. We can do it again and again and again. It's no limit. If you have done a myomectomy for the patient, and if he comes back a second time or the third time, you're going to tell her, now, please, I go in there and then take out the uterus. Here we have got the options of conserving the uterus. Now let's look at the disadvantages. Now for myomectomy, we all know there's a risk of bleeding, there's a risk of hysterectomy, there's a scar in the uterus, and when the patient gets pregnant, delivery we can be daring enough to allow normal delivery if it is a subserosal fibroid, but many times we say, okay, I think it's safer we just do a cesarean section. Of course, there's a risk of post-operative adhesions. There's a risk of infertility because of these adhesions caused by the surgery itself. There's a risk of recurrence. It's done under general anesthesia, and of course, there are complications. You know, all surgeries have complications. Anesthesia, we can cut some bowel, bladder, all that can happen. As we look at HIFU, what are the disadvantages? There's no histopathology. Everybody asks me, you do have no histopathology, how is it? You just have to trust your ultrasound and your MRI and hope there is not a leiomyosarcoma and that it dies. There's a small risk of incomplete ablation. This will depend on the type of fibroid, position, number. We may not be able to ablate a large percentage of the fibroid. Studies have shown that if you have done something like 72 to 75% of the fibroid, it will die. But the little part that you didn't ablate probably may grow back. You may need surgery. If you have not done a good job, you may need surgery. And this is the most important thing for infertility specialists like us. It takes time to shrink. I will explain, I will elaborate on this a little later. Of course, there's a risk of complication. It's very rare, but it can still happen. You can have nerve injury, you can have skin injury, you can have bowel injury. Okay, now I'm going to talk to you all about the speed of shrinkage of fibroid. This is very important for infertility specialists like this. When you have a fibroid that is type 0 or type 1, type 0 or type 1 or type 2, type 0 will be the fastest, type 1 and type 2 will be the second fastest, type 3 and 4 and 5 will be a little later, and the slowest will be, sorry, the arrows are all over the place. The slowest will be type 5 and type 6. Again, I will elaborate on this a little while. So the patient need to understand that the speed of shrinkage depends on where the fibroid is located. Now, I think many of us, or even fertility specialists, don't understand the concept of volume. We just say this is a 5 centimeter fibroid. Yesterday we did a 10 centimeter fibroid. But what is the volume of that fibroid? Now, if you look at a 5 centimeter fibroid, its volume is about 65 centimeter cube. When it becomes 4 centimeter, it is 33 centimeter cube. That means it has reduced by 50%, and it may take 3 to 6 months. I think this is something that we need to understand, that patients get upset. My fibroid is only shrink by 1 centimeter in 6 months, but actually it is reduced by 50% in volume. I think volume is more important, and this is something that doctors, gynecologists, IVF specialists should understand, as well as the patient should understand. And if they don't understand, don't do HIFU, and do a surgery. Okay, in my mind, these are the factors that one should consider before recommending HIFU for fibroids for infertility patients. And these are the conditions, and I'll go through them one by one. Firstly, location. Now, there's a question, does submucous fibroid, we must do surgery? Type 0, type 1, I think I will do a transcervical resection of the fibroid. This will be my first choice. Unless the patient is a Virgo intacta and she refuses vaginal examination or even a hysteroscopy, then I will consider. I've done that before. And they do very well because they will break down and they will come out. As for type 2, we can do transcervical resection, but if you say it is just 10% in the endometrial cavity, the remaining is in the myometrium and it's large. Not many of us are very good at doing transcervical resection. You can give generation along, shrink it, and then go in maybe multiple times to resect the fibroid, but it can be challenging. Sometimes you have to go laparoscopically. But this may be a condition that HIFU can benefit. I've done a lot of cases like this. Always the question asked, like the gentleman has asked, is does transcervical resection cause more damage than HIFU? Or does HIFU cause more damage than transcervical resection? There's no data on that. There's no study on that. I don't think anybody can tell you that you are better off doing surgery for multiple small submucous fibroid than HIFU. We got no answer to that. You just have to discuss with the patient and decide which is best for her. I think that will be an appropriate answer. So, of course, because surgery is a standard of care, we will choose surgery as first line. But if the patient is not comfortable or doesn't want, then we can propose a HIFU for submucous fibroids. I'm not talking about patients who do not want to get pregnant. That you can do. But those who want to get pregnant or those who are subfertile, then you can consider that. This is an example I'll give you. This patient is a 39-year-old lady with enormous number of fibroids in the endometrial cavity. She was bleeding. She was getting blood transfusion for many times. And this is the hysteroscopy. She has multiple submucous fibroids. Some of them are actually maybe type 1, and some of them are type 2. And the uterine cavity is filled with these huge fibroids. Now, I discussed with her, I said, if I were to do hysteroscopy, it's going to take a long time. And not only that, you may have to do multiple times to do this surgery. I can maybe do a laparoscopy, maybe open surgery, and we can remove the fibroid, but we can do HIFU. But the problem with HIFU will be your fibroids will be killed. It may come out, but your pregnancy rate, I cannot assure you. After thinking, she said, I will choose to do HIFU because pregnancy is not what I'm concerned about now. At the moment, I'm bleeding away. I want a most non-invasive method of getting rid of all these fibroids. So we did the HIFU for her. And this was the HIFU ablation. The whole endometrial cavity was ablated. It was full of fibroids we ablated. And 6 months later, all the fibroids were expelled. She has only a few small fibroids in them. But this is my best case. Of course, we always show our best cases. There are patients that, I know some of them doesn't come out, we may have to go in. But for patients with submucous fibroids, we always tell them that we will need to probably go in later to just do a simple TCR trancervical resection because these fibroids are all dead and mushy, and you can go in and just easily scrape them out, even with, by DNC. But whether this is a better option for a patient to get pregnant or not, I am not sure. I am not sure. I tell them that I'm not sure. So you have to pick and choose what you want in this kind of situation. Okay, let's go on to the next one, the subserous fibroids. Now, if you have a fibroid that is subserous 6, 5, generally we leave them alone, but you say they don't get pregnant and your infertility specialist is jumping up and down that you have to remove the fibroids, and they come to you and ask you to do a HIFU, I will generally say no, let's go and do surgery. The reason is because it takes a long time for the fibroid to become small, and they will be jumping up and down, and your fertility specialist will be jumping up and down. The fibroid is there, you're not getting pregnant because of the fibroid. So I will generally choose surgery rather than HIFU, unless the patient insists on doing HIFU. Now let's look at this. This is the most difficult one to decide. The intramural fibroids, so 3, 4, 2 to 5. What are we going to do with them? Are we going to do surgery or are we going to do HIFU? And it's a very controversial topic. We can be either way, we can be correct or wrong. Now, in my mind, this is a review that I did some years ago that actually said that if you have an intramural fibroid of even 2.5 to 3 centimeters, I'm talking about type 4 fibroids, not even type 3. Type 3 fibroids, I think we all agree that we probably have to remove them. But if it's type 4 fibroids, that is not even touching the junctional zone, it's intramural type 4, 2.5, 3, they actually decrease your fertility rate. So if a patient has this kind of fibroid and they come to you and ask you to do surgery, I think it's cruel to do a surgery to cut the uterus to pick up that 3 centimeter fibroid. My suggestion is this is a good case to do HIFU because you just, if it's easy, you just shine them, kill them, and they shrink and they can get pregnant. So this is a good option. But let's look at the bigger ones. The bigger one, if you have slightly bigger, say 4 or 5 centimeter fibroid, intramural fibroids, you have a choice. Of course, you can do surgery. But if they want to do HIFU, can you do them? I think in my mind, you can. This is an example of a patient who had 2 intramural fibroids, maybe 2 to 5 centimeter fibroids. 2 to 5 type fibroid. And this is the contrast MRI showing the fibroids. And we discussed, and I said, I can do this easily. I can do it in 1 hour. I can do a laparoscopic myomectomy in 1 hour for you. Would you want myomectomy, HIFU for this option? And she chose to do HIFU. And so I did the HIFU for her. And this is the HIFU ablation. It's quite well done. And this is 3 months later, the fibroid. And the shrinkage of fibroid was like this. The 2 fibroids, there was a 49% reduction in the fibroid within about 4 months and 58% reduction within 5 months. And then she subsequently conceived and delivered the baby. So this is an option you have for your patients to see whether they will be beneficial for them to do HIFU rather than surgery for patients with intramural fibroids. I hope I'm clear. I'm trying to clarify my mind as well, because I'm biased. I do IVF, I do laparoscopic surgery, I do HIFU. Where do I sit? And this is, in my mind, the way in which you select your patient for HIFU. Okay, let me move on. As far as I said, if you have type 7 and type 8, for infertility patients, don't do HIFU. Go and do the surgery. And even for patients who are not trying to get pregnant, don't do HIFU. Just do surgery, because they are probably better off. But there is no evidence. You're always worried that if you have a pedunculated fibroid like this and like this, if you do HIFU, the fibroid may drop off. But there's been no studies, there's been no reports of this happening. So actually, if the patient wants to have HIFU, you can. But as for cervical fibroid like this, I had a very bad experience. This patient had a large cervical fibroid, so almost 15 centimeters cervical fibroid. Everybody frightened her that if you do surgery, you're going to lose your uterus. So she said, please do the HIFU for me. And I did the HIFU. It was a good ablation, but it took months and years for it to shrink, and she became impatient. So I had to go back and do a laparoscopic myomectomy for her. So don't do HIFU for this kind of patient, especially for those who want to get pregnant. Okay, next comes age. Now, age is a very important factor when you're deciding on whether you want to do HIFU for fibroid, especially for intramural fibroids. Now, if for type 3 and 4, if it's as small as I said earlier, you can consider fibroid. But if it's a larger fibroid and the patient is young, you can consider HIFU because you have time for the fibroid to reduce. However, if the patient is older, and especially if the patient is thinking of IVF, I will not do HIFU. The reason is because the patient will be very upset that your fibroid is not shrinking, and the IVF specialist will be, why is your fibroid still there? So I will be very, very cautious when I'm doing older patients. I say older, 36, 37, 38, this kind of age where they are in a rush. Well, only 5 minutes left. How am I going to finish this? You have to give me a bit more time. So that is my concern. Next is consistency of the fibroid. Now, if your fibroid is vascular or it's got a lot of degeneration, then don't do the fibroid if the patient is infertile. You have to give me a little bit more time. Okay, here is an example of a patient. I'm talking about number of fibroids. If there are a lot of fibroids, then it becomes, oh dear, this is not working again. Oh, yesterday we tested and it worked. Okay, if you have a patient with a lot of fibroids, you can go in and take out the fibroids. But if you do that, it is going to recur. And this is an example of a patient. I'm very sad that it is not working today. Yesterday it was working. Is it running? No. This patient had multiple fibroids, and we discussed again to do surgery or to do HIFU. And then she actually decided to do HIFU. And we actually ablated the fibroid. Sorry, it's not running. And so then she couldn't get pregnant. And then we went and did IVF for her, and she actually conceived. And this one, I want to show this video. I hope you translate. You can see the baby. This is done about 2 months ago. And you can see all the fibroids surrounding the baby. So even if you have a fibroid that is not active, if you have multiple fibroid, you've done HIFU, it will work in these kind of patients. I'm sorry, it's not working. Okay. And this is another example. This lady had enormous, it's a leiomyomatosis, full of fibroids. She's bleeding away. She wants to get pregnant as well, but she said, I want this fibroid to be sorted out. So we discussed, and I said, this one, I actually discussed this with Professor Lian Zhang. I said, you can do, but the patient may not get pregnant because it is full of fibroids. And we did the ablation, and you can see the ablation. The whole fibroid has been ablated, and all the fibroid has decreased. The endometrium, I went back and did a hysteroscopy, has a lot of adhesions, and now we are trying to work out how to help her to get pregnant. So multiple fibroid is a problem. Consistency of the fibroid, as I showed you, this consistency, when you have fibroids like this, I think we should do surgery because it's going to take time and it's going to be difficult. Another is recurrence of after previous myomectomy. Now, this is a good situation. Patient has had myomectomy before, and then they come and do come to you for HIFU, this can be a good situation to do HIFU. The last, as I said, is a patient with keen for IVF or frozen embryo. This is one of a Filipino patient. It's a Filipino doctor who came to me about 2.5 years ago. So all the videos are not working. I'm very sorry about this. We tested yesterday and it all worked. So you see, the patient has multiple fibroids, and she had previous myomectomy, and we did the HIFU, and we did very well. The fibroids reduces, all of them are there. The fibroid it reduced, but she couldn't get pregnant. She went back and did the embryo transfer, and she couldn't get pregnant. And then the IVF specialist keep telling me that your fibroid, although it's become smaller, is still touching the endometrium, and that is the cause of the infertility. So in this kind of situation, I think it's better to do surgery rather than do IVF. Okay, this is what I was worried about. Okay, so this is my pregnancy outcome for my fibroid series. Out of the 10 patients who got pregnant, 7 have delivered, 5 have cesarean section, 1 is spontaneous vaginal delivery, and 1, the patient that I showed earlier, has an ongoing pregnancy. Okay, now I go to the more difficult topic, which is adenomyosis. Now, adenomyosis, the advantage is that we don't have a good surgery. Adenomyomectomy is a terrible surgery. All of you have done it. I've done a lot of them, and they are terrible surgeries. And I've always wished after doing, they don't get pregnant, because if they get pregnant, I am worried that uterus is going to rupture. So it is not a good option. So this is my pet subject. I like this topic. And we can see that for fibroids, you have a very well-defined capsule. You can do the ablation very well within the capsule. Whereas in adenomyosis, it's not the same. It's not the same. You can see that adenomyosis is all over the place. And when you do ablation, it is impossible to do 100%, even 90%, 80%, you're 70, 60, 70%, you're already done a good job. And that is not the problem. The problem is that in patients who have adenomyosis, who want to get pregnant, as what Professor Lian Jiang said, you will have to be careful not to ablate the endometrium. You have to give less treatment. You have to give minimal treatment. If your patient doesn't want to get pregnant, I can do an ablation that gives a lot of ablation, because the whole idea is to actually shrink the adenomyotic disease so that it will come down, the uterus will come down. The more you kill, the better the chances of success rate in terms of bleeding and pain. But if the patient wants to get pregnant, I'm going to do suboptimal treatment. I tell them that I'm going to do suboptimal treatment. You will come back to me next year if you have if you don't get pregnant. So they must understand that. Somebody asked me, what is the recurrence rate of HIFU treatment for adenomyosis? I tell them 100%. It is 100%, because we are not killing everything. It's 100%. We are just helping you to make the adenomyosis volume lesser so that you can get pregnant or you can keep your uterus. That's basically what we are trying to do. So I'm not going to touch on all aspects, which is my lecture this afternoon. I'm going to talk about only those who want to get pregnant. Let's look at those groups who want to get pregnant. I've divided them into 3 groups. They are those who have frozen embryos, those who are still single, and those who want to get pregnant on their own. Now let's look at those who have frozen embryos. It's a group of patients that I like very much, because the IVF specialist has done everything for the patient. They have done IVF, they have done embryo transfer, and the patient has failed. So when they come to me and I do HIFU and they get pregnant, I'm the hero. So I like this kind of patients, because this is the end game. Okay, and I like this because so I have to do the ablation very carefully, and I have to make sure that the endometrium is not involved. I usually give them GnRH for 3 months, and then I will advise to do the embryo transfer 3 months after the HIFU treatment, irrespective of whether the patient gets her menses or not. This is my protocol, my personal protocol after doing for some time. If I give you an example, this lady is a 35-year-old lady, married for 5 years, no children. In 2019, she underwent IVF with 2 frozen embryos. She was given GnRH, and then she did laparoscopy, and then another GnRH, and then they transferred the embryo, and she did not conceive. When she came to see me, she had a 16-week flax uterus, severe dysmenorrhea, heavy menses. She was on tranexamic acid to control her bleeding. And the ultrasound showed a large posterior adenomyosis measuring 9.6 times 10 times 8. And so this is what her adenomyosis are. This video, unfortunately, is working. So this is the adenomyosis, large adenomyosis. And the adenomyosis is more on the right side. And you can see very clearly that the adenomyosis is actually coming right into the endometrial cavity. It is involved in the endometrial cavity. So in the afternoon, I'll be discussing on what are strategies to do for HIFU. This is one case that you are going to ablate and you're going to probably hit the endometrial cavity. And this is my power setting. For those who do, we did it for 1,635 cycles at 146 minutes. And this was done in September 2021. I was doing this with my teacher who came down from China to do it with me. And it is the ablation after 3 months. It was fairly well ablated. And this is the transverse view of the ablation, also fairly well ablated, but the endometrial cavity was involved. So this is a shrinkage over the 6 months. It was a 71% reduction in uterine volume. So before HIFU, her volume was 940 centimeter cube. A normal uterus volume is only 60 to 80 centimeter cube. So it's almost 10 times the size of the normal uterus. And at the end, in February, it came down to 265 centimeter cube. I sent her back to IVF specialist, who actually checked the TA125. It was a little high, and so she repeated the GnRH and then did a frozen embryo transfer. And then she got pregnant, and then recently she delivered this baby. This is a good. This is I become a champion. I become a hero in this kind of situation. And this is not the first one. I've already had 8 pregnancies like this. So this is an area where the infertility specialists can discuss with the HIFU specialist how you can use HIFU to help your adenomyosis patient get pregnant. And this is my series. Out of the 8 patients that that we have done, 5 have delivered, 4 by cesarean section. 1 patient unfortunately had a stillbirth at 28 weeks, and she actually delivered vaginally. 2 miscarriages, and 1 is ongoing. This ongoing patient is actually in the United States. She came all the way down to do HIFU. She went back, did a transfer, and she's pregnant now. We are waiting for her to get to deliver. The next group is the patient who are keen for spontaneous pregnancy. Now, these are young patients who have adenomyosis who want to get pregnant. Very challenging cases to do, because you can ablate, and you have to ablate very lightly, and you have to tell the patient that you give them GnRH, and then once the period has come, ask them to conceive on their own. And I know in China there are many pregnancies. I have not been fortunate. I have not got a spontaneous pregnancy after HIFU. Many a times we tell them, don't wait, please do IVF. If you don't, you may have to do a HIFU again, maybe in the near future. Okay, this is an example of a patient. It's a large adenomyosis. We did the ablation, and then this is 3 months later, and we are still waiting for her to conceive. So, and this is another patient, and this is that same patient with a 55% reduction. So the next 2 questions I would like to answer before I finish, sorry, I'm taking a lot of time, is does HIFU affect ovarian function? Professor Lian Jiang answered this question. And does HIFU affect the endometrium? We are always thinking whether this is going to happen or not. As for ovarian function, most of the fibroids we are going to do are in the middle here. And when you shine the energy, it is going to be in the center, and the ovary is far away. But when you're doing very lateral fibroids on the right side or fibroids on the left side, your energy may pass through the ovary into the fibroid. And we know from our studies that the focal point, the point where there's maximum energy, is where the maximum energy is, which is where the temperature goes up to 65 to 75. And in fact, you can put a hand inside and it will not burn you, but there is slight accumulation of energy on the lower part. Will that affect the ovarian function? People have done studies. This is one study that there have been 5 or 6 studies. This is one study where they did the AMH, anti-Mullerian hormone, before HIFU, and then they did after HIFU, and they found that there's no change. So unlike uterine embolization, this is safe during for patients who want to get pregnant. There's no ovarian involvement. The next question is, does HIFU affect the endometrium? Now, when you are ablating a fibroid on the anterior wall, you're not passing through the endometrium. But when you're ablating a fibroid on the posterior wall, you pass through the endometrium to reach the fibroid. So there's a concern whether the HIFU energy will affect the endometrium or not. But this is a very difficult study to prove. And this is one study that I've seen. What they did is they took the endometrial samples and looked it under the electron microscope for many different things. And then they did HIFU and then did the endometrial sampling again and look at the endometrium. It's not been affected. So you can safely say that even if you shoot the beam right to the posterior involving the endometrium will not be affected. In conclusion, very sorry, it took a little bit longer. Offering HIFU for patients with fibroid must be done very carefully because we have a good option, we have myomectomy. But I think if you think logically, there are a lot of patients who will benefit from HIFU in patients with fibroid. And as I said, it has its own advantages and disadvantages. For adenomyosis, I think it is probably superior. It's superior to adenomyomectomy. And not all adenomyosis are either the same. Some, the ablation is easy, some is difficult. If you're interested in this, you come to my afternoon lecture. We'll discuss on this, the challenges of doing HIFU for adenomyosis. And in women with adenomyosis, we have difficulty in conceiving, especially after failed IVF. HIFU is an option to shrink the adenomyosis before frozen embryo transfer. So if somebody with adenomyosis comes to me and she's in the late 30s, I tell them, go to a IVF specialist and do the IVF. Get the embryos frozen first and then come and see me. I won't do the HIFU before they have an embryo. Even better, transfer some embryos and fail and then come to me. I'll be very happy to do the HIFU for you because I don't want the IVF specialist to blame me for causing her not to get pregnant. I want it as failed, and then I am doing the HIFU. Of course, it is not possible because this kind of patient may have only 2 embryos, and then they say, I only got 2 embryos, please do the HIFU for me, and then transfer, and then we will discuss, and then we will do the HIFU for them. There are many challenges in performing HIFU for these patients, including how much to ablate and how to avoid the endometrium. The next difficulty is to decide when is the best time to do frozen embryo transfer. Don't think protocol. My protocol is like this. I will do the IVF, get the embryo frozen. I will do the HIFU for her, and then I will give her GnRH analog. The aim of giving the GnRH analog is to shrink the uterus faster and become smaller. And this is always happens. It actually shrinks much, much faster. You can get 60, 70% reduction in volume. And there's enough studies to show that the smaller the uterus, the better the pregnancy rate. And you do the embryo transfer 3 months after the HIFU. And you also check your CA125 because sometimes the CA125 is a little bit high. You may want to add a bit more GnRH so that the CA125 becomes lower, less than 35. And then they do the embryo transfer. And I do the embryo transfer without inducing periods. I just give them estrogen valerate and make the endometrium thick and then do the embryo transfer. And all my pregnancies are using this protocol. In patients who want to get pregnant on their own, then you should do HIFU and then tell them that you will have to try to get pregnant as quickly as possible. If you don't, go ahead. Okay, thank you.